Hello friends and welcome to today's video, which is a very interesting case of a septum, complete uterine septum extending from the fundus to the endocervix. So we had a 31-year-old female with a previous one spontaneous first trimester abortion, anxious to conceive. Her clinical examination was normal, but on a 3D ultrasound we noticed that she had a complete septum extending from the fundus to the endocervix. So she was categorized as a U2B kind of congenital uterine anomaly. Both the adnexa were normal and there was nothing else remarkable in the scan. Now we've planned her for a hysteroscopic septal resection and we'll try and discuss the important points of the surgery as we'll see it now. Thank you. So initially we enter with a vaginoscopy technique, getting into the external os of the cervix as you can see and navigating our way to the internal os. As we enter the internal os at the endocervix, we can see a clear-cut septum extending from the fundus to the endocervix, dividing the endometrium into two cavities. This is the typical owl-eye appearance that we see in a complete septum. Now, this septum seems to be fibromuscular. So, the first step that we do after entering with our L-loop resectoscope is we make the marks for the end point of our cut. Now, the most common error that people make in a septum is overcorrection, resulting in perforation. So, to prevent that, what we do is we go and assess the level of the ostia, see the pericorneal region, and then we make a mark with our resectoscope to mark the end point of our resection at that level. So, as you can see on the right side, we've made the mark. Similarly, the corresponding mark on the septum. So, these mark are end points of correction. When we reach these points, we stop the correction and we constantly orient ourselves with those endpoints so that we know where we are at the resection. Then with an L loop, we start the resection. It is always prudent to cut with the L loop going in a motion from proximal to distal with complete control over your hands so that you don't overcorrect or go into a wrong plane. Now the correct plane in a septum is the one exactly in the middle where both the walls very beautifully retract into the anterior and posterior wall. So frankly speaking, typically there is no real reason to resect or excise a septum. As long as you incise it in the correct plane, the two walls of the septum go into the opposing walls and it corrects itself. Only the fibrous portion, like the white portion we see right now, may need to be excised. But otherwise, there is no real need to excise and remove and scoop out that septum. Go in very short bursts of energy proximal to distal and keep orienting yourself again and again. We are using a 22 French bipolar saline resectoscope with a L loop attached to it, and the distending medium used here is normal saline. Now when you're using normal saline, a use of a hystromat is highly advisable because the fluid dynamics become quite complicated in a surgery like this if it takes longer. So to typically calculate your fluid deficit, using a hystromat would be very good, but even if you don't have it, be sure you have a proper and keen eye on your fluid dynamics. As you can see, when I'm cutting in the correct plane, that septum is pulling itself on either side. Be in the center. Don't go either preferentially into the anterior wall or the posterior wall. It is very important to stay in the center of the septum as you cut it. And every time keep aligning yourself with the end points of your dissection. A little mechanical push with the resectoscope also helps sometimes to show you the right line of cut. It's always important that we understand that a septum should rather be undercorrected than overcorrected, because even a physiological uterus does have a little arcuate tendency. So you don't want a convex fundus, but rather a little concave with a little remnant septum is always preferable to perforation. So cut proximal to distal, short bursts of energy, go from one side to another so you're well oriented with your cavity. In a septum, a very important part is also the post-operative management. So what we do at our unit is we insert a 8 number Foley's catheter into the uterus and distend it with 3 ml of normal saline. This keeps the opposing walls separated because both the opposing surfaces are now raw areas which have a very high tendency of adhesion and forming an Asherman syndrome later on. So you keep that Foley's intrauterine for 7 days. That helps these walls to re-epithelialize and grow new endometrium. Also very important is the use of hormones. So you give a high dose estrogen for 3 cycles that builds good endometrium over your cut edges, and after a 3-month window, if you do a repeat 3D ultrasound, you will find a good cavity with a nice endometrium building on it. Nowadays, certain companies also have special intrauterine triangular catheters that are coming in. So that is also something that can be used. As you can see, now we are approaching the muscular part of the septum. The initial part was the fibrous part, and now we are approaching the muscular part. So as it's going, again I've assessed my endpoint. So this was a proper fibromuscular septum, which after cutting gave a very nice and roomy uterine cavity. Now the fibrous portion can be resected, which in the end we will just see. I've shown the fibrous portion there, and that can be resected with a U-loop on a resectoscope also. Septums do increase the chances of having abortions in the first trimester and also infertility to a certain extent. So in terms of a complete septum like this, it is always advisable to go for a hysteroscopic septal resection, because it is not a very complicated or difficult surgery with risks involved, but the risk reward ratio is really phenomenal. So it's a good option to go ahead with this surgery. Now, as you can see, slowly we are reaching the end point of our septal resection, and our markings have been reached. Gently cutting in short bursts. The setting is an underwater cautery. We've set it at 100 setting, 100 watts, and that is providing sufficient energy for cutting the tissue. As you can see, slowly we are reaching a very nice normal looking uterine cavity. Be very careful not to use your resectoscope near the cornual region, because that can damage the ostia, the tubal ostia. We're almost approaching the end of our surgery. As you can see, we have a beautiful roomy cavity. Now in the upper portion, you can see the muscular part, and as I slowly come down to the lower portion, which now looks like a triangular impression on the posterior wall, you'll see it looks very fibrous. These are the last few cuts. Initially, preoperatively, be very sure you have a good diagnosis clinched for this uterine septum, because if you confuse it with a biconvert uterus, then you're in for some trouble. So be sure of the septate uterus and then only go ahead with this surgery. Ideal mode of diagnosis would be a 3D ultrasound with a good reporting. MRI also gives you a good report, but then that's not required for just diagnosing of a septum. There, as you can see, the lower part is completely fibrous. It was extending till here, and that was the fibrous part, and the upper part was the muscular part. Now it's formed a nice roomy uterine cavity, and we'll put her onto hormones for 3 months, keep the Foleys for 7 days, and that should solve her problem nicely. Thank you so much for watching. I hope you enjoyed.